Jaren, may I start? Good evening, everybody, and a very, very warm welcome to all those who have logged in to hear this very pertinent webinar, especially given the current COVID times. For a lot of us, the transplant coordinators who are listening in, working in the hospitals, and for many of us who are working in NGOs promoting organ donation and transplantation, we have been getting a lot of calls, of desperate family members exploring lung transplant for their loved ones post-COVID complications. And do we really know what to say to them? Do we have a clarity on what kind of a response do we need to give to them? And it was precisely one such query about 15 days ago that made me call up Dr. Attawar. And when he started telling me what I really should be telling the family, I felt that we needed to have this webinar so that all of us have a clarity. There were a lot of things that I wasn't aware of. And I think we need to be better prepared to handle such queries. And that's why this webinar today, COVID post-lung transplantation, is lung transplantation the only option? What else can be done? Where do these families go? Who do they seek out? What needs to be done? So we have a very esteemed panel today. Let me begin by introducing our experts. We have with us Dr. Sandeep Attawar. Dr. Attawar is the chair and director of thoracic organ transplants and assist devices at the KIMS Institute for Heart and Lung Transplantation in Hyderabad. Dr. Attawar has earlier worked at the Manipal Heart Foundation and the Narayana Vidalaya. In 2001, he set up the Greenfield Heart Surgical Services. And since 2011, Dr. Attawar has expanded his repertoire to thoracic organ transplantation and mechanical circulatory support. Dr. Attawar now focuses solely on a top-down realignment of pre-existing cardiac and respiratory services into heart and lung transplant centers. He has done the same for Gleneagles. It's Gleneagles? Is that how we pronounce it? Yeah. Gleneagles Global Hospitals at Chennai, Bangalore, Hyderabad, and Bombay over the past 3 years, before he's moved down south as the founding director of the Solid Thoracic Organ Transplant Program at KIMS Hospitals. During this period, his team has performed 278 thoracic organ transplants, of which 165 were double lung transplants, with over 28 left ventricular assist device implants. And Dr. Attawar has also kindly agreed to moderate this session for us today. We have with us Dr. Kumud Dhital. Dr. Kumud Dhital is a cardiothoracic and transplant surgeon. Welcome, Dr. Dhital. Dr. Dhital is also the chairman of the Heart and Lung Committee at the Transplantation Society, as we know, the TTS. Dr. Dhital has earlier worked as program and surgical director of heart and lung transplantation and MCS at the Yashoda Hospitals, Hyderabad. Director of Cardiothoracic Surgery and Transplantation and the Program Director of Heart and Lung Services at the Alfred Hospital, and Professor of Cardiac Thoracic Surgery and Transplantation at Monash University at Melbourne, Australia. Dr. Dhital has been a consultant cardiothoracic and transplant surgeon at the St. Vincent Hospital in Sydney, Australia, at Royal Papworth Hospital, Cambridge, UK, and at the University of Pittsburgh. His special interest, in addition to the comprehensive cardiac and thoracic surgical practice, is donor organ preservation and donation after circulatory death heart transplantation. In fact, I remember hearing you, Dr. Dhital, at the DCD workshop that we had organized at Fortis along with Dr. Seth. Very warm welcome to Dr. Unmil Shah. Dr. Unmil Shah is the consultant transplant pulmonologist at the Institute of Heart and Lung Transplant at KIMS Secunderabad, and is also a consultant transplant pulmonologist at the Gleneagles Global Hospital, Mumbai. Dr. Shah's team, headed by Dr. Sandeep Attawar, has done 160 lung transplants, predominantly double lung transplants, 32 combined heart and double lungs, and 88 heart transplants since 2017. That's phenomenal, Dr. Shah. And post-COVID, they have done 14 post-COVID acute respiratory distress syndrome, end-stage lung disease, double lung transplants on ECMO in this period, August 2020 to April 2021, or actually now 14, as he told me a little while ago. And during the COVID pandemic, they've done almost 50 thoracic organ transplantations. So very happy to have you here. I'll also quickly introduce two gentlemen who have very magnanimously agreed to share their experiences. They've both recently undergone lung transplants, and they have agreed to be here with us to share their experiences. We have Mr. Pranav Munjal. Pranav is a practicing architect since the last 7-8 years. Hello, Pranav. And he's originally from a small town in Punjab called Malot. I had never heard of the town, but has been practicing architecture in Ludhiana currently. And Pranav underwent a lung transplant in 2021. And we have Ravindra Babu Dasri, who's been a seafarer for the past 40 odd years, retiring finally as captain. Hello, captain. And he belongs to Hyderabad. Ravindji was scheduled to join a ship on the October 5th last year, but couldn't as he tested positive for COVID-19 and of course had to, due to complications, had to undergo a bilateral lung transplant at KIMS Hospital on the 29th of November, 2020. So over to you, Dr. Attawar.
Thank you so much, Pallavi. I think it has been an incredible journey for more than anything else. I think for individuals who have gone through this torment and this crisis of being unwell acutely from COVID, and then facing this very unpredictable future, given the course of this illness and the I would say all the hype surrounding it, all the insecurity and the uncertainty being diagnosed with terminal COVID. We have two great examples of individuals who have fought through this battle valiantly with their families, and they've come out unscathed in some way. At least having the opportunity to live normal lives. Why I thought, and I'm very grateful for both of them and their consent to be on this panel, was issues like COVID require human stories. We need a human angle, and there cannot be a better example or a better testament to that than these two valiant fighters who've come back to normalcy and probably would be sharing some of their thoughts on how they tackled this illness and this period of insecurity that their families went through while they were on a hospital bed hoping to recover. I'm deeply grateful for Kumud having consented to attend this as a panelist. Kumud is much more than what Pallavi described in her brief introduction. Kumud is also credited with having done the world's first organ transplant, that is successfully transplanting a sequence of hearts from circulatory death patients. That is, the heart has stopped beating in all these donors before they were retrieved, reanimated or brought back to life, and then transplanted successfully in patients with end-stage heart failure. Kumud is one of the people that I have always looked up to in the field. It's a great pleasure and honor to have him with me on this panel. As far as Unmil is concerned, Unmil is a very young, passionate, and a very talented pulmonologist. His entire focus is transplant pulmonology. He gave up his entire interest in interventional and regular pulmonology when he diverted his complete attention towards transplant pulmonology. He has been a true pillar for our service, and what we have achieved in treating many patients like both Pranav and Ravi, a great deal of that goes to people like Unmil and the rest of the team. I am very grateful to MOHAN Foundation for having picked up this topic, and Pallavi especially, because in our discussions we thought about how we could bring across all these great scientific minds, Kumud, Unmil, and many others in the community to make or decipher all the complex questions and the decisions that many patients and their families have to make in these times of crisis. So with that, I'll open this forum. And my first question would obviously be to Kumud. And I would like to ask you, Kumud, is how would you unpack all of this? How would you begin to unpack all of this complexity for largely our audience being donor coordinators, transplant coordinators, people who are first responders to many families that have questions when they have been told by local teams and local physicians that, you know, your son, your brother, your father has terminal COVID. It's a terrible problem. We don't see the lung improving. He needs a lung transplant. I mean, the solution is directly a lung transplant, right from being on a ventilator. There is no other solution, especially in a country like India, where lung transplants were unheard of a year ago. They're obviously right up there in the center spotlight. And it's a very difficult process for many of these coordinators to unpack and unravel or probably even explain. So would you please give us some idea on how you would approach this? Kumud, you have to unmute yourself, Kumud.
Pallavi started in an introduction saying exactly that the problem was for them facing questions to which they did not have answers. And in fact, we in the clinical community have not been terribly good at giving that information out. And it remains very institute dependent. There is no proper guidelines that have been written in India for the local community. If anything, the guidelines that come from abroad, particularly, for example, a 10-point guideline on what to do about lung transplantation post-COVID from the Toronto group. The ISHLT, the International Heart and Lung Transplant Society, regularly updates its own advice on what to do with thoracic solid organ transplantation. So the first thing to address is this issue that you mentioned about what should we do with this advice that our patient, our nearest and dearest, our loved one needs a lung transplant. And that's where the problem starts. I think we're overselling hope. I think we have an environment of false hope. We need to be far more realistic. And what that is that the relative is now come to the end of normal standard of care of even ventilatory support. And they may or may not have been instituted on ECMO therapy. The subsequent transfer to a higher level center, either for ECMO or a consideration of lung transplant, should not be one of sending for a lung transplant. It's transferals for continuity of care at a higher level center. It may or may not eventuate in a lung transplant, because until you or I or our equivalent colleagues have seen the patient eye to eye, examine them thoroughly, you will not know they're fit for transplant. And there are a host of relatives who believe that this transfer is going to result in a lung transplant, and often it does not. Even the ECMO bridge is not for a day or two, unlike other temporary organ failure, putting a, let's say, ECMO for a heart problem or an isolated lung problem. And it is so different from the ECMO requirements that we faced a few years ago, now going back, 2009 with H1N1, where they did well with ECMO and survived. Now the ECMO for COVID is required for 3-4 weeks or beyond. And some are beyond 6 weeks or even longer. And you've got a wonderful series of very prolonged ECMO supports which you've successfully transplanted. But those are very, very few that have done well in the context of the the overwhelming workload that is coming our way. And so we have to be realistic. I think we need to be truthful. We need to say there's far more assessment that needs to be done at a higher tertiary level. And that has implications for whether or not you transfer. Are they in a fit state to be transferred? Are they beyond salvage for a lung transplant? Now, this is a real conflict because the relatives will grasp at even a 1% chance of survival for their loved ones. But that 1% does not translate well into a hopeful future when, in fact, even if you and I do a successful transplant, their stay in hospital is so prolonged for rehabilitation that in the Indian context, the risk of infection is so high, the chance of ever getting home in a state that they would wish to be home, and in the state to enjoy their life at home, and in the state to interact with their loved ones at home is highly, highly unlikely. And so we just have to be honest. We all have to have the same story so that Pallavi and her colleagues have a simple set of answers that they can give, that for which there will not be a conflict between yours, mine, other units across India.
Great. Thank you, Kumud. Unmil, if I can ask you this in context to what Kumud just mentioned, how would you approach this if someone called you up, maybe a donor coordinator, maybe a family called you up saying, Dr. Unmil, this is the situation where my young brother, who is 23 years of age, who has no comorbidities, is now diagnosed COVID positive. He's in the hospital on high flow oxygen. The doctors say that his saturation is dropping. He might probably require mechanical ventilation. And probably from there on, we do not know where it would go. He might also require an ECMO. So how would you probably address this issue? Because this seems to be a common line of complaint or a common, what would I say, a panic call to a transplant coordinator or a donor coordinator.
Yeah, I mean, it's a very practical question. I mean, in the second wave specifically, we have seen many of these referrals coming with the impending, intubation, impending mechanical ventilation, patient on NIV of 100%, PF ratios down, and then the referrals come to the team about how to go ahead. So I think the first important is to, have a detailed clinical summary obtained from the treating hospital, speak to the treating doctor, understand what has the treatment the patient has received, discuss with the family about the course of the disease. And also we have a assessment form prepared where it's almost a 15 points to have a basic idea about what is the general condition of the patient, whether the patient has a candidacy for even initiating ECMO or not. Later on would be the question about the transplant, but first and foremost to know whether patient has a single organ dysfunction, whether or patient is into a multi-organ dysfunction, what is the age, what is the BMI, that is the height and weight. So basically understanding the general candidacy of the patient, getting a detailed clinical history. When was the RT-PCR positive? When did the acute lung injury start? Because if we see the guidelines, I mean, whatever the 10 points guidelines, whatever we have, whether it is ISHLT or from the Toronto group, they have clear-cut mentioned that it has to be 4 to 6 weeks from the initial clinical signs of respiratory failure. Now, if we underline this statement of initial clinical signs of respiratory failure, so for that, it is very important to go into the detailed clinical history about to know when the patient started deteriorating, whether the patient was earlier on oxygen, went to NRBM, then to an NIV support, and then got intubated. So I think interacting with the treating doctor, very important to understand the course of the disease, interacting with the family to understand what are their expectations, and also getting a brief assessment form filled up where we would have a general idea about whether it's a single organ or multi-organ, what is the neurology of the patient, how is the neuromuscular condition. So once we have these details, then again we have a second round of communication with the treating doctor, with the family, to explain what all possible options such patients have about going ahead. Now, if the patient is on NIV 100%, and now there is an impending mechanical ventilation, I think now the general consensus worldwide is to go for early intubation, not to have a delayed or a terminal intubation. Once mechanically ventilated, then the question comes about how is the compliance of the lung, how are the PF ratios, and then accordingly we can take ahead about, there are various methods available to, improve the PF ratios for the initial phase of the ARDS, do a recruitment, do a prone ventilation, diuresis, prevent fluid overload. If that doesn't work, the PF ratios worsen, the carbon dioxide goes up, then we have to think about ECMO. So I think it is a step-by-step approach to a query or the referral which comes, and it has to be a team approach where the family has to has to decide, the treating doctor has to decide, and we have to decide. So it's basically a teamwork where the consensus is decided upon and then the things are taken ahead.
So taking that back to Kumud, I would like to ask you this. In simple ways, could you make it easy for our audience to understand when would you make the decision to move someone from mechanical ventilation towards ECMO institution?
Dr. Attawar, if I may, even before Dr. Dhital asked that, if for the lay people out there, what is ECMO?
Oh, yeah. Okay.
Sure. Good. Okay. ECMO is what stands for ECMO, stands for extracorporeal membrane oxygenation. It can be in the form of either supporting both heart and lungs or just the lungs alone. And that depends on where these cannulae, these pipes are placed. So typically in the COVID scenario, it's a matter of assisting the lungs. And therefore you would have a pipe typically in the groin that is fairly large, and it draws blood out, puts it through an oxygenator and a pump that then puts the blood back in to another vein, usually in the neck. Now, for people of fairly smaller size or who don't need as much flow, there is a single cannula that can be used in the neck. It's a lot more expensive, but these are the two typical configurations. And we won't go into the other aspect, which is the veno-arterial or so-called VA ECMO, which is for heart support as well. Now, very few people with COVID have a cardiac problem that also needs supporting. And so we won't go into that. Majority are called VV, veno-venous ECMO support. Now, when do you need that? You really need that when you have exhausted your non-invasive first ways of supporting the patient on oxygen therapy to high flow, to potentially then having to have ventilation. Now, one of the things that's really been missing is a proper dialogue between clinicians at our end of extreme care of the very, very sick, and those that are having to deal with it on a daily basis. Now, I've been on an ECMO retrieval, and I can see that in the public hospital. I was amazed at the amount of work that they had to face from doctor-patient or nurse-patient ratios that we in the corporate setting have a greater luxury of. And therefore, I understood why it was almost impossible to have a dialogue, as Unmil suggested, between the treating clinicians and us to find out all that important history. And often you have to rely on the relatives who also are limited in the contact they can have with the physicians and, of course, their loved ones. So there is a difficulty of trying to get the very essential information first. But when you then need the ventilation and you're intubated, that's helpful in itself. That's the next level that most hospitals are able to cope with. But the problem is, if you want to make them, give them the best chance, you really have to try and do various things with it. You have to try and alter the position of the patient. So turning them on their fronts, if you will, proning. We know that that helps, but very few institutions have the capacity, manpower to do that on a regular and necessary basis. Now, the complication then happens is that on a ventilation, if you've been on a ventilator for more than about a week, typically the patients will get inserted. Well, you'll be having a tracheostomy or a little hole in your neck to ease ventilation. That allows you two important ways of managing the patient. One is that you can try and awake the patient up. And this is not happening in the majority of centers. Because if you wake the patient up on the tracheostomy, you can engage them, you can give them physiotherapy. They're only limited by the fact that they cannot speak to you. Now, given that anyone ventilated for COVID is unlikely to come out of a ventilation for a number of weeks and might need ECMO, it is imperative that we try and keep them awake as much as possible, because otherwise they will lose so much muscle. They will get ICU neuropathy, they will get myopathy, loss of muscle, loss of nerve function, and they will lose so much muscle that, in fact, you will end up, if it's a transplant candidate, with no muscle to then help you breathe. The lungs alone will not let you breathe. They're just bags. You need the strength of your chest wall and your diaphragm to be able to breathe properly. And that then the rehabilitation becomes so bad, as I said earlier on, that you will not get them out of hospital. So even right back, when the patient's being ventilated, you have to think about the end game of where you're going. And so you have to start proning. You have to assist these patients with physiotherapy, which has to be aggressive. And again, in many hospitals, they do not have the sufficient manpower of physiotherapy to do it 2-3 times a day. But now what happens is you've exhausted your ventilatory ability to support them anymore. Their oxygenation is very low, limited. The CT scan shows very destroyed lungs, and there's no improvement that's worrying. You're now worried about infection elsewhere outside of the lungs and having now multi-organ problems. So what do? You say, now, as long as Unmil said, there are criteria, well-written criteria and guidelines for who should be a recipient, a candidate or not, then you refer on to a transplant center. Now, the transplant center, if it has all that detail, well, can advise you about, listen, it's not worth it. Please talk to the family. This should be now palliated. Or, wow, we should give this patient a chance. 23-year-old that Sandeep mentioned, absolutely, single organ failure, who's exhausted ventilatory support. You would do whatever to try and make sure this chap got a chance for a lung transplantation. Absolutely. So you would transfer them to a center. And of course, you're stuck with where do you send them? Where do you send them? Now, if you look at the MOHAN Foundation website, they have a list of approved heart and lung transplant centers in India. And you'd be surprised, there are about 100 plus or minus for both organs. And yet there are only probably 3-4 that are actually doing any volume of work that should be done at this level. Because if you're not doing a decent volume, you should not be attempting it in the situation of a COVID patient, which is perhaps the most complicated thing you could be doing, not just the tricky surgery, which we can talk about, but in terms of the actual team that is used to looking after these patients cohesively, to look after them, particularly post-operatively, to make sure they're guarded against the infection, which is almost inevitable without somebody knowing very well the complexity of immunosuppression and interaction of drug-drug interactions, which when to try and mitigate against infection, that is a crucial knowledge that people like Unmil have, who are dedicated transplant pulmonologists. And if you don't have those dedicated transplant pulmonologists, it is exceedingly difficult to keep patients alive in the long term, let alone the short, complicated phase. So that is a normal progression of how you go it. But I would again go back. Don't assume you're transferring for a lung transplant. You're transferring for a higher level of care that may, all things being well, allow your loved one to have a lung transplant.
Awesome, awesome. I think that was brilliant. Thank you. Unmil, could you also expand a little bit on some of the challenges that very critically unwell patients, when they transit from mechanical ventilation, especially when they are ventilated for many days, with no recourse to a center with advanced ECMO facilities, simply because of the volume of patients desirous of services that are limited to very few centers and very few geographies, given the fact that there are very few air charters that are available to be able to transfer these patients, given the fact that there are so many guidelines for transferring patients who are COVID from one state to another, the state bureaucracy, then given the fact that you're looking at multiple teams trying to work between each other with no experience of working together in the past, how do you probably look at all of this coming together eventually in a transfer of a patient to a virtual facility that is probably able to take care of them, and the challenges that the treating team would face in those initial few days with dealing with myopathies, steroid overuse, multi-drug resistant infections, non-conscious patients simply because they were on a vent with great amounts of sedation, and a great deal of mental, what would I say, degradation of many of these patients. And I'm sure Pranav and Ravi, who are with us, would probably throw some light on their personal experience a little while later. But I just thought that let's move some of the clinical work to begin with, so that we can set a stage for a more broader human discussion. So any thoughts on that, Urmi?
I think practically there are two challenges. One would be the clinical challenge, and other would be a logistical challenge, considering the pandemic situation. Now, clinically, as we have prolonged mechanical ventilation, patients on ventilatory support for more than 10 days. Sometimes, what we have seen as compared to the first wave and the second wave, the first wave, the referrals were pretty late, more than 10 days, 15 days on mechanical ventilatory support, and then being referred for higher tertiary care, whether it is ECMO or transplant. As vis-a-vis as the second wave, I think there was a lot of awareness among the medical fraternity, and the referrals were pretty much earlier maybe in the first week of the acute lung injury. Now, as the days goes on mechanical ventilatory support, there is a lot of the diaphragm muscle weakness which starts creeping in. There is disuse atrophy, or the diaphragms become weak. There is neuromuscular weakness unless until the patient is undergoing a aggressive rehab there in the referring hospital. There is critical illness neuropathy. That means the upper limb muscles and the lower limb muscles become weak, and patients are not able to even move their limbs against gravity. It's total weakness. There are repeated infections because they have been on prolonged ventilatory support. So repeated episodes of sepsis or higher antibiotics, antifungals being given. It's a post-COVID scenario. There is a viral because of the post-COVID scenario, the immunosuppression because of the post-viral illness is profound, and maybe post-tocilizumab, which is the drug given, and that's why we had these repeated infections. Plus, maintaining a prolonged adequate nutritional support is very important. If that is not maintained, the proteins levels drop in the body, the fluid starts getting accumulated. So these are the various clinical challenges which the transplant team also faces when the referrals come pretty late, and even those challenges have to be faced by the treating teams there till the patient is optimized for even transfer to a higher tertiary care. As far as the logistics part is concerned, patients on mechanical ventilator support with high oxygen requirement, the patient just cannot be transferred just on a ventilator. So for that, if the high ventilator requirement is there, maybe there is some kind of BP support medication is also required. There is a basic need to initiate ECMO there locally, which a transplant team or a third party has to do that, and then only the patient can be airlifted to a tertiary care center on an ECMO support. So that is a logistical challenge which the families usually face, where they have to understand about what is the ECMO or what is the ECMO, how it has to be initiated, why it has to be initiated, why the patient cannot be airlifted on just on mechanical ventilatory support. And obviously considering the pandemic situation where the charter flights are also available in lesser volume, again the cost of initiating, the cost of airlifting the patient from one center to another center also multiplies. So I think you have logistical challenges, you have clinical challenges which also have to be troubleshooted before we think about airlifting such patients.
Thank you, Unmil. Kumud, I just needed to ask you, with all this complexity of teams traveling in and out to be able to evacuate patients from remote locations, how would you secure the safety of medical staff who are involved, not just in the retrieval process? How would you talk to them? How would you motivate them? And how would you look at taking care of them, not just during the surgery, but also in the post-transplant setup in the ICU?
Listen, motivating isn't such a difficult thing because the team, like yourself, this is what we're there for. I mean, this is something we do every day. They're engaged by the fact that they have patients who need to be treated and saved. Their lives at stake. And, you know, just that example of a 23-year-old, could be 33-year-old, 45, 53-year-old, doesn't matter. The point is they all are not just individual, but attached to relatives, families, loved ones. This is what we do, whatever, whether it was lung transplant, heart transplant, anything we do. So the team is sold. And we actually, so it surprised me that even those that when we're trying to be most careful about this infectious status, we seem to just throw ourselves into it. And the nursing staff, I mean everybody, allied health, everybody, it does whatever, you know, and I've had arrest situations in highly infected COVID patients. And now remember that those ECMO patients or those ventilated patients who are being transferred for tertiary care in a timely fashion are still in their infective phase. So you've got the worst infected patients. And when the arrest happens, you'd be surprised how little PPEs and things are possible to put on if you're doing CPR and trying to put ECMO into these patients. So it is all you can do is to thank everybody. Say, next time, let's try and get better. How can we, you know, foresee this? What can we do? So it's an evolving thing. But of course, you're absolutely right. That we try and limit the number of people that are involved in all of this. We try and separate out the teams if we can, so that the team that's retrieving doesn't have to then come and take part continuously for the other parts of it. We need to separate out the teams and the nurses, the physicians and nurses team, including the cleaning team and so on, that is involved in the areas where there's potential of infection. So this majority of hospitals are very good at. Where manpower becomes short, you have a real problem because you only need one person to cross or abuse that barrier to then spread. And as you and I know, then our healthcare workers, staff, colleagues have become positive and have had to go and isolate. And sadly, a few have required to be in ICU, and even sadder, even fewer, thankfully, but nevertheless tragic that they have lost their lives amongst our own colleagues. So this is happening all the time, but in the context of so many more lives that are lost every day unnecessarily because untimely referral and also practice itself of the medicine, in that Unmil mentioned, you know, he's mentioned toxilizumab, all sorts of other things that we use, plasma therapy and so on, unevidenced. In fact, the general message is don't use these things. If you do, there's a certain time, remdesivir, that you can use. But you find majority of hospitals throwing the whole bucket at every patient unnecessarily and sadly often increasing the risk of infection, particularly with the higher doses of steroids. And we've seen this resurgence of fungal infections in patients, which becomes the nightmare postoperatively if you get mucormycosis, or supposedly called the black fungus. So, the other thing, of course, is during the surgery, again, you have to be absolutely careful about where they are in their disease status. And Unmil is, again, he's mentioned, this is critical, to know when the patients start becoming symptomatic. So normally, if you're symptomatic and you're not in a hospital setting, you can go home and isolate you for 2 weeks. You don't actually need to have a repeat test as such, because you're considered by then to be free of being infective. The same thing applies even to a critical patient after 3 weeks. So what we've done is to say, well, let's go from the time of, recently was to go from the time of the RT-PCR that was positive, and let's give it 3 weeks from there. It's a critical patient, which takes you up to 28 days anyway, and then they are definitely non-infective, right? So you can treat them as such. And what's also not happening is the patients are not being considered to be moved out. They're being left on the COVID ward in many places when they shouldn't be. They should be moved out. And of course, a positive test at that point often is meaningless. It's often a false positive, and people aren't looking at other things that you can look into that test to see whether or not, in fact, it's likely to be a positive test or not. There are clues there that you can glean from the PCR test. But assuming if you think the patient is still positive, then of course you've got to be very careful about your surgical team, limiting the number in theaters and in the ICU, making sure everybody's got their appropriate PPR for that setting. And of course, not forgetting that the donor has become an issue now, because majority of donors are likely to be also have a risk of becoming positive. And we've had that. We've had donors with the last minute who may have had a negative nasopharyngeal swab, but we are absolutely determined to say, no, we want a deep lung samples with a bronchoalveolar lavage, that's which you do with a bronchoscope, a flexible bronchoscope, and those have come back positive. And so you have to abandon that using that donor, because you're going to put everybody at risk, not just your staff, but most importantly, the recipient. And this has happened, of course. It's been written. There's been a case in the States where the donor ended up being positive only retrospectively known, where the surgeon and the team were then positive and had to isolate, and thankfully they were okay. But so this is just, again, comes down to teamwork. And you can't achieve this level of safety for your staff and colleagues without having the teamwork. As long as you're in a team, it keeps you within the discipline. And I think that's really crucial. And you and I couldn't do our work without teams.
So Unmil, now
we have a lot of questions from the audience. So do you want to bring in Ravi and Pranav now? Or
yes,
take
please.
questions?
Just talking about it. Yeah, please go ahead.
So
what
do you want to do?
Yeah.
We take one or two questions, and then you can bring in Ravi.
Yeah.
Okay.
So why don't you go ahead with them, Pallavi?
Okay. So somebody wants to know: is it can ECMO be hired?
Yeah, yes. So the hospital can hire the ECMO. Trouble is, now that people know two things with COVID, one is that the lung might actually be a useful organ to us. So people have a slightly better respect for the lung instead of just this piece of offal, which is good for us and the patients. But the other thing is that the use of ECMO has gone sky high. And unfortunately, not everybody's going to be benefiting from an ECMO. So we have this overuse of ECMO in patients who we could have known that they wouldn't have benefited. And sadly, just like a ventilator, to the detriment of those that are waiting who might actually benefit. And there's only so many in the country. And often they're all used up. So, and some hospitals have them, but they think they won't lend them out because they think they might need one. So the same practice for all devices in hospitals, nothing different. But yes, so you can, through the air rescue teams or certain hospitals, get access to ECMOs, either because the institute or the air rescue teams possess the ECMO machines because they've bought them, or because they've been able to hire it through a third party, which are usually the companies that have imported these devices into India.
So while we are at this, can we also kind of get an idea of where are ECMOs available in our country?
So the transplant centers and even some non-transplant centers, ICUs have them. Some very good sort of pulmonology type centers will have them, and cardiothoracic, so heart transplant, so any sort of thoracic transplant, but also quite a few more advanced cardiothoracic services have got one or two ECMO devices. So they are available, but often you will find that they're all in use. And those that are not in use are sadly kept behind because they feel, what will I do if I have a patient in the city that needs it?
Yeah.
And yeah.
Okay. So Dheeraj Vilasrao wants to know, after post-COVID lung transplant, are there chances of antibodies rejection?
Unmil, can you take that question, please?
Yeah. So I think for any lung transplant, whether it is a recipient of COVID or non-COVID, usually there are always two possibilities, either of rejection or infection, which can happen because of the prolonged immunosuppression. Now, rejections can happen post-lung transplantation. There are varieties of rejections, but I would not go into details of those. So irrespective of what has been the recipient, whether it is a COVID recipient or a non-COVID recipient, there are always possibilities of having rejections, but they are never, most of them, they were never life-threatening rejections. There are, medicines, good pharmacological treatments available to tide over them. So it is not found that, the COVID patients would have more rejections and the non-COVID patients would have less rejections. There is no data available. But what from our team experience, what I can say is we have done around 14 lung transplants in COVID, and most of at least the 10 of them having undergone the surveillance lung biopsies, we have found very, very less or negligible incidence of rejections, biopsy-proven rejections. So maybe whether it is related to the post-viral immunosuppression status of the patient, where the immunity has been just hit so badly that there are no much antibodies there, or maybe cells to counter the graft, and obviously the immunosuppression goes on. So I think that has been our anecdotal experience, that we haven't found much of biopsy-proven rejections in post-COVID lung transplants. But yes, theoretically, practically, the rejections can happen post-lung transplantation, irrespective of the indication, whether it is COVID or non-COVID, but most of them are manageable.
I'll take one more question before we invite our guests to share. This is Kundan Rajak, who's actually watching from Nepal. And he's saying, my father has post-COVID severe pneumonia. How can we coordinate to transplant lungs?
Well, I might answer that by saying, given that I am originally from Nepal, but the sad thing is that we don't have a thoracic transplant program in Nepal as we speak. And this is not the time to suddenly start one, because you'll have a disastrous outcomes. So the question is, of course, it is sad because you can't transfer them anywhere for internationally for transplantation, where you have to have access to cadaveric organs. Now, so in India, now largely, there are only a handful of states where your overseas people are allowed to have access to cadaveric donations. And even if before they're considered, they are offered out to across the nation through NATCO to all other Indians that might be waiting in different states and different transplant programs, rightly so. And so given the context now, the pressure on lung transplant with the low donation rates for organs in India, the chance of anybody from abroad being able to have access to lung transplantation is almost nil. And that's where I think we need to be careful about giving false hope to people. And so unfortunately, there's little we can do for this patient. The other thing we don't know is how old they are, whether in fact they are candidates at all. So often you'll find that if they've had post-COVID pneumonia and have they been ill for a considerable time, the chances are they've picked up a lot of factors that would make them unsuitable for a sensible transplant outcome.
Thank you. Dr. Attawar, please.
Yeah, thank you. So, Unmil, in all this doom and gloom, I do understand many coordinators would also love to share a positive or probably a message of hope for many of these candidates or people who potentially are seeking out for lung transplantation. How would you tell them that there is a possibility that an ECMO could be a bridge to recovery, or probably even ventilation could be a bridge to recovery given good ICU care? That many of these patients probably do not even require to discuss lung transplantation with their clinicians. How would you give them this message of hope?
So, I would like to begin with quoting, there's a beautiful English parable which has been correlated with the lung transplantation, and which I read in one of the articles published in the Cardiovascular Thoracic Journal. Just 2 minutes of time, that there was a boy who was, putting or throwing back the starfishes into the sea, which were washed ashore, trying to help the starfishes. Now, a man approached the boy and told, "What are you doing? I mean, there are miles of beaches to be covered, and there are thousands of starfishes." So he just threw one more starfish or put it back into the sea, and he told the man that, "I did make a difference to that starfish." So that boy is akin to a lung transplantation. To sum it up, there are thousands and millions of COVID patients. There would be a few patients who would be critically ill, requiring ICU care, maybe ventilatory support. Maybe among those, there would be a select few who would be going for ECMO support. And among those few, there would be a select few who would really be a candidate for lung transplantation. But if we are able to at least select those few patients who have the candidacy for the ECMO support, or the candidate which could be a bridge to transplant, or it could be a bridge to recovery, or there would be a patients who would have the candidacy for the transplant, and if we are able to if they are able to undergo lung transplantation, I think we are making a difference, a significant difference to those select few. So as I mean, the pandemic has been really, a sad part in the last 1.5 years, where millions of lives have been lost. But despite this doom and gloom, I think if we are able to provide services as per the science, decide about the ECMO candidacy as a bridge to transplant or a bridge to recovery, decide for the lung transplantation, and if we are able to either provide ECMO services or lung transplantation and make a difference, I think it goes a long run.
Lovely. Pallavi, could you just jump in? We would love to have a few words from you, Pranav, Ravi, going forward.
Raviji, I'll start with you, Raviji. Thank you so much for waiting so patiently through this whole discussion. We would like you to share your experience. What did it mean? What happened, and how did you decide to go for the lung transplant? What kind of challenges did it impose upon you? So very quickly.
Now, you want to go ahead first? Or you talking to me, Pallavi?
I was talking to you, Raviji. But,
okay. I think Pranav is also quite impatient waiting. Okay, greetings to all and namaste. This is to most eminent doctors in front of me right now. I think this is appropriate greetings in this time of pandemic. Well, I never thought I will end up in a hospital. I never did see the doors of any hospital in my life. But unfortunately, October 1st, everything turned upside down. I had some SOB problems earlier, shortness of breath earlier, but I never thought, then when I got this COVID, got affected by virus, then my saturation levels were dropping quite rapidly. Then I had to go to the hospital. Then hospitalized immediately because seeing my situation. I did go to one hospital. Then they tried to put me on ventilator, but then saturation levels were not really coming up. They were not able to bring up the saturation levels. And finally, after 10 days in that hospital, I was transferred to KIMS. And then, because there's the only hospital which had all the facilities, things. Then, so from ventilators, then slowly I was put on ECMO because nothing was helping me cope up with these saturation levels. Then, unfortunately, what happened was there was no donor available for me. I was put on ECMO for almost a month, and that was pretty hard. Because I don't know anything. It's quite an emotional thing.
I can imagine.
Excuse me.
No, it's all right.
Yeah. So practically, I was immobile, just lying on the chips going around and everywhere. I was just staring at the ceiling. Sit for 1 month, move this way or that way. Quite a traumatic experience. But my wife, she gave a lot of support and gave a lot of encouragement. My wife and my son, somehow I was able to cope up with that. Finally, I got transplantation was done on 29th November. Then again, I had to stay in the hospital for about a month before I was discharged. It took really another 3 months for me to really come back to a sort of normalcy. I wouldn't say 100% normal. Sort of a normalcy. And then, because all the thanks should be go to doctors, not giving God's. Our and overweight. And of course, team of doctors. Dr. Ravi Bharti, Dr. Vijil, Rahul, team, and nurses, and everyone, right to the cleaning staff, very good care of me. Finally, it is you who have to fight it out.
Yes.
You need to have a lot of willpower.
Yes.
Because I was there, I've seen the other side. Never I thought I will come back. It's very, very traumatic. Okay.
No.
So such a long time in the ICU.
Hospital. Yeah.
Then one of the adverse effects I had was this gangrene that affected my 3 fingers. They need to be amputated. And that could not be helped, fortunately. But I'm glad to be alive.
Thank you,
Sandeep,
Raviji.
who is my living God.
Yeah.
If I may just interrupt you, Raviji, I just wanted to ask you how would you say that a donor organ impacted your life? Because I think that's the center of everything that has happened for you. That you were so desperately unwell, and how the effort of individuals that work within the foundation, that is MOHAN Foundation, and all the trainees that go through the foundation, what an impact they can make in the lives of so many patients like yours. Like you, suffering from terminal liver, kidney, heart, lung, so on and so forth ailments, where they spend countless hours trying to convince. You met Shankar, you know Shankar quite well. They spend countless hours trying to talk to donor families, persuade them, implore with them, give them an understanding of how they can make a difference in someone else whose life is impacted by the end stage damage of some of their organs. What would you like to say to them?
I think donors definitely God sent, obviously, because I mean, they have given me life. I was again reborn. All the thanks to the donors, definitely, their families who are consented to, donate the organs that patients like us can continue living. It itself is a very great contribution. It's I don't know how to thank them. Beyond any words, we need more donors like that.
Just keep smiling, Raviji, and keep facing the world with
Yeah.
courage. And that's your biggest thanks to these families. That's what they want. That's why they say yes.
They are also, definitely they are unseen gods.
Yes.
We have living gods like
most definitely.
Sandeep, Attawar and his team, and whom I can see physically. But there are also other gods.
Absolutely, that you cannot see.
Donating organs so that we can live.
Yeah.
Keep our families.
Yes. Thank you, Captain. I'll bring in Pranav at this point. Pranav, Raviji, if at all I can use the word, was fortunate because he happened to be in Hyderabad. You are in some remote part of the country which has nothing to do with lung transplants. How did you go about that process, and what did it mean for you?
Well, actually, it's a very long journey. Like Raviji, I could see the tears coming out of his eyes. But right now, I do not have any tears left in my eyes to come out. I have only the smile to give everyone. So I'm a post COVID-19 lung transplant patient. Earlier, I was admitted in SPS Hospital, Ludhiana. Then it was a very, very steeply timely decision taken by Dr. Sandeep when he decided to airlift me to KIMS Hyderabad. So I have many things to say, but I'll just scrutinize all the things. So thank you for giving me this opportunity to speak in front of the cream of the hospital industry. And I would like to start by saying that we make a living by what we get, but we make a life by what we give.
So true, Pranav.
इसलिए कहते हैं कि अंगदान महादान है. And everyone should pledge to donate their organs. And Mohan Foundation is doing a fantastic job. If the donor could be a reason for giving me a new life, why can't I be the reason for the same? Even though I don't know the donor who was my donor, but I take a moment to thank the donor and his family that they have given me a new life. and I assured that their son would live a very beautiful life in me. That's a very big point, that he is still living a life in me.
What a beautiful testimony, Pranav, to
And
organ
yes,
donors and their families. Really, there is nothing without them. There's nothing without a donor.
वो donor अमर हो चुका है.
जी, जी.
He has gone beyond his life actually. उसी को ही हम अमर बोलते हैं, जो अपनी लाइफ के बाद भी एक नई लाइफ
जीता रहता
जी
है.
रहा है, वो अमर हो चुका है. And
Thank
as
you
we
for
know,
saying this, Pranav, because we keep talking about it all the time. But coming from you, coming from someone like you, it's such a powerful statement. And
yeah, and as we are aware about that, this pandemic has actually shattered the developing nations. So the science of organ transplant is no less than a blessing, and we have to admit it. Yeah, and I have something more to say. And now I would like to say something about a person who is a no ordinary man and is an angel sent by God Himself in bringing back the life from the dying ones.
Pranav, we'll talk about
The smile has already come on his face,
Pranav.
and he is none other than Dr. Sandeep Attawar, and I really admit it.
Pranav, I'll just interrupt you. You have made a brilliant, inspiring message for many of our donor coordinators. I would only request you to continue doing it, please. I do not want this to be.
Yeah, definitely, sir. Definitely.
Very touched
I am,
by everything that
I am
you
a,
say.
yeah.
I think everything that we do as clinicians, and Kumud will join me in this, and I know that for sure, that Unmil, Kumud, and everyone will totally agree that we are only clinicians who have science with us, and we have good intent and determination in our heart. But all of this is possible only because of donors and people like Mohan Foundation who continue to and I pray that their ilk only expands. We are only small part of this entire process. Though it fills us with great pride, I don't think we deserve any of this. But we are truly very grateful to what.
And I hope Ravi and Pranav will continue to be with us as we, take forward this work. And I hope you will be spokespersons for organ donation in the time to come. We are coming to the end of our time, but I would like to take a few questions which are very relevant. Sridhar wants to know, is it possible for partial lung donation, as cadaver donation may not cater to the demand?
Okay, so this is the tricky business. So this is a living lobar lung donation. And in fact, the Japanese have just done this for the COVID. In fact, Japan is probably the only program that has any sort of decent outcome from the living lobar lung donation for transplantation, the other being historically where it got started in California in the USA. The trouble is that you are potentially putting 3 people at risk. You have a 300% potential mortality. And to risk this in an adult, often it's not sufficient just to have 2 lobes, one from each relative given to you, because it's got to go so right that imagine you're then living without a lung, which can happen for cancer therapy. You can remove 1 lung and you can lead a good life with the other single lung. But if you have 2 lobes, you can have the equivalent of having 1 lung out. If you get even the slightest bit of infection, your resilience is so small that the chance of you doing well in the COVID situation is exceedingly small where infection rates are high. So outside of established programs that do that, and as I said, the only one that's sensible at the moment with good outcome data is in Japan. This is not something to be trifled with.
No.
By putting 2 other patients at 2 other individuals at risk.
So we have to continue to rely on deceased donations. And
any insight on the size match and things like that, Kumud? I mean, any.
So I think this is a really, really crucial. So apart from the absolute need for Pranav and Ravi and patients like him who've done well to be our champions for organ donation in the community, because that's really missing. The community is not seeing Ravi and Pranav out there. Once they start seeing, they'll see that the therapy is good and people can have a second chance at life. And we're missing this. That's what's going to drive organ donation. So that is really important. And now, sorry, just remind me, the last bit you mentioned was?
The size mismatch,
Yes,
because the lobe being small.
So unlike the heart and liver and kidneys, heart and lung matching is far more difficult because the heart's got to be matched for power. You can't put the heart of a smaller size body into a big body. And similarly, the lungs, you've got to size the chest cavity that is likely to be at the time of the transplant in a patient. And the longer they've been on a ventilator, longer they've had the disease condition, then the chances are the lungs will have shrunk down and the chest cavity will have shrunk down. You will not necessarily get in the proper size of lung you need to put in. So you may have to trim, you may have to remove the odd lobe or so. So it becomes a lot more difficult to match. So not anybody is, even if you match the tissue typing, it's called, or the blood group, necessarily matches the heart and lungs as readily as for the other organs.
Yeah, thank you so much. Shalaka wants to know, please address the exorbitant costs involved in lung transplant in COVID patients. We are seeing fundraisers for rupees 1 to 2.5 crores. Can you please discuss the cost breakup? Are the transplant teams counseling patient families through this level of bankruptcy? Are the transplant teams giving a clear picture to the families of possible future costs of a maintain a lung transplant through the recurring infections in India and rejections?
I think Unmil could take that answer. Kumud could take it too.
Sure. Unmil, go ahead.
Yeah. So basically, I mean, the cost of the transplant, I mean, the whole process, if we see when the patient is airlifted from the one center to a higher tertiary care center, whether the ECMO initiation, the number of ECMO days, waiting on the wait list for the transplant, awaiting the organ donation, the donation happens, the transplant is done, and then the post-operative period, which can be prolonged specifically in this post-COVID phenotype, where we have pre-operative challenges which also influence the outcome. So if we consider all these factors, this all leads to the higher cost of the whole process. Now, I mean, there are, I mean, the ECMO runs, the per day ECMO runs, the ECMO cost, the machinery cost, the consumable cost always adds on to the patient's bill. I mean, I would just put it this way that, I mean, why do we have so much of long wait list, in India? I mean, that significantly impacts the overall total expenditure of the whole process. If organ donations are, the awareness increases more throughout the country, there are more organ donations happening, I think that would significantly impact and reduce the wait list. If that wait list reduces, I think the process will be much faster, and I think the cost would come down. So I think everything boils down to the rate of the organ donation. Now, if we compare the WHO statistics about how the India does on organ donation as compared to other international or foreign countries, I think we have a very dismal rate of organ donation, even though it has increased over the past 5 to 10 years, and there is a lot of awareness being created, but still we are less at compared to what the other countries have. So if we can address though that is a core issue. I mean, we need to have organ donations. We cannot rely on living low bar donations, which does happen in very few countries like Japan. Most of the heart lung transplant programs in India are cadaveric based, or all of them, and hence we need to have the organ donation rate going up, and that would significantly impact and reduce the total expenditure.
Having said that, it is an expensive transplant. I think what she wants to know is the patient counseled, family counseled enough to understand?
We have the process of speaking to the family right from day one, speaking to the treating doctor right from day one. After the family has understood the process, the family is also made to connect with the financial team. The financial team apprises about what would be the total process cost right from day one of ECMO, the ECMO initiation. If the transplant happens, then what would be the tentative post-operative period. So the whole expenditure is explained to the family, to the treating doctor also, and then the consensus is taken into consideration. The family is in the driver's position. The family has to decide whether they will be able to afford or not, understanding various unpredictable challenges what we have. See, we don't know when the organ donation will happen on the wait list. How much time would it take for the post-operative period to, whether it is going to be 4 weeks or 6 weeks, we are not aware. But considering all these unpredictable challenges, obviously these all challenges are taken into consideration while discussing the finances. The whole picture is made very clear to the family, to the treating doctor before the patient is airlifted. But these unpredictable challenges, if we are able to overcome, then I think the overall process, the cost would definitely come down.
Sorry, Dr. Dhital.
Just to add a penny's worth, that it's not just about donation. While that is the most important hurdle we have, the other one is a timely referral. So when patients get referred too late in their diseased evolution, natural history of their disease, then you see, if you got patients arriving for lung consideration of lung transplantation, who cannot even do a lung function test, who cannot even walk 6 minutes. They are so far deconditioned, their chances of doing well and trying to escape the hospital within the 2-3 week time period is very small. And therefore the costs add on significantly with the complications beyond that time when you'd want to be sending them home 2 to 3 weeks. I mean, even in the world's best center, a lung transplant discharge, the average time is about 3 weeks. So for after a lung transplant. So if they have to stay longer, it'll be because of complications or infections or because they were so deconditioned, they were referred too late. And then Unmil is absolutely right. The costs just go then rocket sky high.
So Dr. Dhital, connected to this, Shankar Ganesh wants to know, what are the indications that patient on ventilator and ECMO needs a transplant? When do they say yes for a transplant?
Sorry, forgive me. I've just got a really...
I know.
Just one second, forgive me.
So Dr. Attawar, do you want to take that question?
I think Urmil can take that.
Okay.
So,
what are they?
So indications for transplant on mechanical ventilation, I mean, obviously, there are some practical points which have been elicited by the Toronto group and by other groups as well. So first, we have to consider the age of the patient, whether the patient is above the age of 65 or it's below the age of 65, because there have been studies where transplants or ECMO performed above the age of 65, it has met with poor outcomes. So we have to be very practical about whether the patient has a candidacy for transplant or not. Secondly, the height, weight, or the body mass index, how obese is the patient, that also influences about the general candidacy. Third, the CT scan picture. I mean, we have been doing HRCTs or the CT scans of the COVID patients, and we come to know whether there are radiological evidences of reversibility or irreversibility of the lung injury. Now, if you have an irreversible radiological signs on CT scan, then probably we know that probably the lung is not going to improve and might head for an ECMO or a transplant. Fourth, how much has been the duration, whether we have given significant time for the disease to improve on its own or with the medicines. So if there have been, at least we have to wait for 4 to 6 weeks from the initial clinical signs of respiratory failure. That doesn't mean that patients have to wait on 4 weeks on ventilatory support. The initial clinical signs of respiratory failure would start from whether patient goes on from an routine oxygen support to a non-invasive ventilation with the ARDS picture on the CT scan. So the clinical history is very important. Fifth, we should be aware of what are the general contraindications for lung transplantation. The patient shouldn't have those contraindications where that would jeopardize the candidacy for the lung transplant. And sixth, if the patient is awake, if the patient also, we need to discuss with the patient. Obviously, patient would not be able to speak, but at least patient needs to be aware about what is happening, because if the patient is not motivated, if the patient is not aware about just awakening after the lung transplant, I mean, it can just play on the psyche of the patient. So this few, and obviously, I mean, the blood gases, where they will be able to tell us whether the oxygen status is maintaining well or not, the Murray score for more than 3. So these are all medical parameters which we also assess clinically to understand whether the patient has a candidacy for transplant or not. So all these 6-7 points have to be taken into consideration before we decide for whether the patient is going for ECMO or transplant, whether the infection is predominantly controlled or not, because patients have been on mechanical ventilator support for a couple of days. So I think we need to have this whole clinical picture into consideration when we decide about the next step.
Thank you so much, Dr. Unmil. Mayuri wants to know, can COVID recovered patient donate lungs in case of brain death?
Awesome question.
That's a very significant, a very important and pertinent question. So,
especially for a
there have been guidelines published by the International Society of Heart Lung Transplantation about a donor who has a past history of COVID vis-a-vis a donor who has an exposure or a contact with a COVID positive patient. So if there is a donor who has a past history of a confirmed COVID, I mean, there are 4 or 5 points which we need to consider. First, the patient should have recovered, the donor should have recovered by the time, I mean, he's landed up for a whatever the event, whether it's a trauma or whether it's some neurological event which has landed up in a brainstem death and patient is on mechanical ventilator support. So first, patient should have recovered symptomatically completely from the COVID disease. There should be at least more than 21 days of the period given after the recovery of the COVID illness. Third, the patient should have the donor should have the RT-PCR negative, and it should be a deep respiratory sample, because here we are going ahead with the lung transplantation. So either a bronchial lavage or a tracheal aspirate has to be done, no nasopharyngeal test swabs to be done. It has to be a deep respiratory sample. Fourth, the CT scan of the donor. I mean, nowadays we are doing CT scans for every donor for screening for COVID. So the CT scan should not have any evidence of COVID infection active, or any sequelae or any chronic lung injury. So the lungs have to be pristine. So if this all 5-6 criteria are met, then definitely one can think about going ahead with the organ donation in a past history of COVID.
Dr. Attawar, we have a lot of questions, but we don't have any time. Will you permit us to send those questions to you?
Yeah, I think Kumud, Unmil, me, all of us will be very, very glad to answer as many questions as possible.
So I would request the listeners to write to info@mohanfoundation.org if you have questions that, I'm so sorry, could not be addressed. Yes, Doc, and I also wanted to bring in Dr. Sunil Shah.
Very good, webinar. Why don't you take another 10 minutes and answer some of
Yeah, I that's what I thought.
Okay, all right. Dr. Dhital had very categorically told me, and I couldn't even thank him before going. So, yeah, he had another webinar at 7 o'clock. So what is the life expectancy after lung transplant in India and abroad?
Unmil, would you like to take that?
Yeah. So, I mean, obviously, I will just first summarize what is the statistics as far as the worldwide figures what we have. So as per the International Society Registry of Heart and Lung Transplantation, we have the 1 year survival projected at 85 to 90%, the 5-year survival projected at 60 to 70%, and 10-year survival projected at 40 to 50%. So what does this mean? I mean, whenever I counsel my patients, I always tell that suppose if I do 100 transplants today in 2021, in 2022, out of 100 patients, my 85 patients are going to do very well. So that indicates that 1 year survival of 85%. That is what it indicates or means to a layman person. Now, there is a worldwide people, the worldwide literature where people have survived for more than.
Dr. Shroff?
Sorry.
Yeah, it's okay.
So there are people worldwide, people have survived for 20 years and above. There are various papers and articles published post-lung transplantation as well. Coming to India, obviously, we have, I can speak on behalf of, we don't have a single registry where we would be able to give a figure about, or considering all the centers doing a lung transplantation. But as far as I would say about the team, my team, we've been doing transplants since 2017, and we also have a 1 year survival of around 80 to 85%. Now, on an average, they say worldwide the survival is around 7 years, but it's an average. You can go above more than 7 years as well. As far as the lung transplantation, the survival considered in a COVID as well as non-COVID, it's too early right now for a data to come out, because the COVID disease itself is only 1.5 years old to predict what would be the survival, a 5-year survival or a 10-year survival in a lung transplantation post-COVID. But I think this, what has happened is in the last decade or so, with much better understanding about the transplant immunology, with better medicines available, with better expertise available, with better surgical skills, the transplantation, the survival post-lung transplantation has definitely been showing an increasing trend, upward trend. Yeah.
Thank you so much. Hemal wants to know, is the status form for patient filled by the coordinator? Do they have access to the form? How do they go about this? The status form that you mentioned right in the beginning.
So the assessment form, we usually give it to the family who has approached us. We also give it to the treating doctor. The ICU doctor has to fill that assessment form, which are the 15 parameters, and either the treating doctor or the family, the relatives can WhatsApp us the assessment form, and then we would again discuss with them.
What are the chances of recovery in post-COVID fibrosis?
So obviously, if you see the data, only 80 to 85% of the COVIDs are mild COVIDs. There would be around 10% of the patients who would be having a severe COVID illness, and around 5% of them would end up in ICU care. Now, we have seen a good number of patients where the, specifically mild to moderate category, where over a period of time, they do improve. The fibrosis is not always irreversible. It all depends upon, how the disease began, whether it began with a mild condition or whether just patient landed up with a ARDS, which is acute respiratory distress syndrome. And even in patients of ARDS, all do not head to transplant. There are a significant number of patients who do recover. So I think the timely management, the timely intervention, the right dosing of steroids, avoiding few medicines, better ventilator strategies, I think these all play an important role. Preventing infections, maintaining nutrition, I think this all will play a very important role.
All right, I think we really must end up there, otherwise it is going to be a never ending. Dr. Shah, may I request you to come in and thank our panelists and our, our recipients. They have been so graciously. Are you there, Dr. Shah? Is he on the call?
While we wait for Sir, I just wanted to say this. I think one of the things that we could not speak about with greater clarity was the fact that COVID fibrosis, like Unmil just said, is something that has taken so much of our imagination that most of us believe that this will not regress. The strange part and the very welcoming part is we've seen significant reduction in COVID fibrosis in many patients, and there have been remarkable regression in some of them within probably a month of walking out of the ICU. Even when they walk out of the ICU, their X-rays or CT scans look pretty pathetic, though their gas exchange and oxygenation looks reasonable. Yes, they do have symptoms of something we call long COVID, where for quite some weeks after recovery, simply because the body's taken such a severe toll, like even with Ravi and Pranav, though they have good functioning lungs, the body, the mind takes a lot of time to recover from that intense trauma. To imagine that they are in an ICU setup, completely aware of everything going on around them, concerns that doctors and nurses would raise every single minute saying, oh, blood pressure is down, this is happening, that is happening. And there are no filters in an ICU. When patients are awake, it requires a tremendous deal of resolve from their part to, and I can only imagine how Mr. Ravi just broke down, towards the end of he's a very brave man, but it takes more than courage. It's an extremely tormenting experience, and we can completely empathize with what patients go through. And to see them right here, sitting in front of us, while giving credit to somebody like me, I find myself so small in this entire process, because there are a million people that have contributed to them being on this chair today, attending this webinar. There are a million people. When I say million, truly takes a village to ensure that they are well. Donor coordinators, families, the transport services, whether it be air ambulances, airline agencies, to imagine that a CRPF personnel takes special initiative to allow that organ box to travel from the door of the airport terminal to the aircraft without asking for any security check. I think that requires courage. He doesn't ask. He says that organ is vital. Pranav is getting that organ. Let's ensure that we can cut down ischemia time. There are a million people in this process. The policemen, the flight attendants, the pilots themselves, and we have routinely seen pilots cut down flight times by 10 minutes, 15 minutes, simply because they know there's an organ on board. So it's remarkable. In what in a country like us, which is so fragmented in many ways, and when I see these political discourses, we see we are a very fragmented country. But to save one life, like Ravi's life, so many people who did not even know him came together to just make it happen. And it all began from that donor hospital and that donor coordinator who gave us that small sliver of hope. And then everyone just pounced at that opportunity, and everyone worked together. The liver teams, the kidney teams, and all of them worked together to make that 7 or 8 organ transplants happen from that one donor. I think this meeting we should summarize and probably culminate in respecting all the tremendous work that MOHAN Foundation does. And many more organizations like you, all your students, all your trainees. I think we would be nowhere without you. And I'm truly, I fill up a little bit when I say this, but I truly believe that this is a great opportunity for people like me to be involved in a science which requires so much of human material, which requires so many people to contribute to make it successful. It's not like a coronary bypass where a brilliant cardiac surgeon can do a great job and the patient gets well, is relieved of chest pain. Here, one individual, if he needs to survive, it needs an entire village to contribute. And I think that's what makes transplantation so special. And I'm only so glad to be just one solitary cog in that wheel. And thank you so much, Pallavi, for making this happen. I don't know whether we'll have an opportunity like this again too soon, but I think we must have more of these dialogues where we have survivors come and just share their stories.
Yeah, yeah.
Young coordinators can be more inspired. You know, they feel that they, in the middle of the night, they can talk to grieving families with the courage that they know that Pranav and Ravi are alive today and they're living normal lives simply because of the work that they do. So let them be the motivating icons for all of us in the works that we do.
So beautifully put, Dr. Attawar. So beautifully put. I think also a lot of questions that are coming in. So I think there's a disclaimer there that there is no one glove fits all solution in lung transplantation. It is very unique to each individual and has to be treated as such. Dr. Shroff, any last words from you, and you thank our...
So, Pallavi, thank you, and thank you, Sandeep. Thank you, Kumud. I know he's not here. Unmil, Raviji, thank you so much, Pranav. So thank you for coming here. You know, Sandeep, I want to just take off from where you left, and you said that you need an entire village to make this happen. You're absolutely right. And I'll just go a little bit beyond that entire village. You know, this thread starts sometimes with a awareness which you may have done somewhere, and somebody may have heard what organ donation is. And when there is tragedy in the family, that someone who heard you, it becomes a trigger to start a conversation within the family for organ donation. Believe me, Sandeep, this has happened multiple times. And those conversations then lead to a telephone call, maybe on a helpline of one foundation. And this has again happened even from far off places like Dubai, where we got a call and the Dubai authorities were not even aware that there was a brain dead donor in their hospital. The donor's family called because he had heard about organ donation from someone like us, and he calls on a helpline, and that donation happens. So that thread, that village, it just doesn't end with that. It even goes beyond that. And that little trigger, that little conversation saves multiple lives. And I think organ donation and transplants bring the best of humanity together, believe me. This is what encourages us, keeps us going, despite all the discourses which goes on the television, which I don't watch anymore, to be honest, because it just puts me off totally, So believe me that that's why this cause is so dear to us, and that's why we keep working against all odds. And yes, you're right, it happens all at odd hours. And today, I must also tell you that 10 to 15% of donations which are happening in this country, the families are coming forward, saying that I want to donate organs for my loved ones, which nobody believes. People think that people will say, the general perception is nobody will say yes to organ donation. That is not true. That is not true, believe me. We are very giving people in India. And a little support to the family, about, giving them a conversation on organ donation. Many no's will come yes, and that's what we do. Our conversion rate at MOHAN Foundation is close to 65%, be it corporate hospital, be it government hospital, across the country. The biggest challenge when we started 24 years back in this program was to create belief among the medical personnel first that organ donation is possible, and people will say yes to organ donation. I think that is what the biggest challenge was. And today, 24 years now, we have come very far. At least nobody says organ donation is not going to be possible. That number is getting less and less. So again, thank you very much for bringing this, wonderful session together, because so many FAQs have been answered. I request you all to put some of those, question answers together so that we can put it on our website. Believe me, the questions are unending. Yeah. I know Pallavi, kind of truncated this here, but we could have gone on for another hour.
Easily.
There's so many people from all over the country asking. And, these webinars are being transmitted on different, social media, and the questions will keep coming for a long time. So be prepared, to answer those questions. And again, thank you very much. Have a great weekend. Stay safe. Thank you.
Thank you so much. Good night, everybody.
Thank you, Pallavi, Pranav, Ravi.